So I thought I'd just kind of briefly, I know we're going to keep it short so we can have discussion, which would be great, talk about basically make three kind of points or explorations. One is to look at, well, as it were, on the kind of the primary side, if we look at the causes of ill health, it takes you very strongly, actually, in my view, to behavioural issues, but also big society. But on the on a kind of a secondary, or the administration of health, also has big effects, particularly big society, both efficiency but in the quality of the character of healthcare. And there are strong ties essentially between both the behavioural and the big society angles. I'll try and at least make that case. So on the first bit, on the behavioural sort of causes of it, well, I mean, it's well known, I've talked about it myself and others have too, that as WHO and others have noted, more than half probably of years of healthy life lost are known behavioural factors, smoking, drinking, so on. And yet actually that isn't particularly the focus of our spend or our effort in terms of what we do in healthcare. I thought actually even in the Darcy review this came through a very powerful stat, which was even, let alone mainstream health spending, even if we looked at the research end of it, that on the one hand, if you have this sort of huge almost dominance but certainly massive effect of known behavioural factors, and he said, well, how much of our health research is spent on behavioural factors? And the estimate comes through of less than 0.5% of health research is on behavioural factors, and of that 0.5%, most of it is on medical compliance. Why don't people take their pills, basically? So the discrepancy is very, very marked indeed. And in principle, of course, if we can move some of those underlying behavioural causes, the health impacts are very large downstream. I mean, as Gus, the Cabinet Secretary, who actually chairs our steering board on the behavioural side, has often remarked in the past, you know, from his time in Treasury, he felt that he did at least as much to improve health of the nation by just putting up duties on tobacco. I'm sure you've heard the same, Chris, from him. So, well, what are the kind of things you might do? I mean, I won't go through the whole framework. We've used loosely this thing called Mindspace, which is a mnemonic, essentially, of a series of kind of behavioural effects that you can use in practice. So, messenger effects, incentives, norms, defaults, and so on. I won't go through the whole list, but I'll just give a few examples and drawing a little bit on that paper. Those of you who watch these things closely would have noticed the white paper on public health had a very strong reference to behavioural factors and indeed kind of nudge type approaches. And the follow-up paper, which you mentioned, Chris, was sort of to fill in some more concrete examples of what that would look and feel like. Of course, today we also have announcements around alcohol and pricing, which again is part of the same story. In fact, astute observers would notice we didn't talk about pricing in that document, partly because we knew it was coming out shortly. So let's just take a few examples. So incentives, well, we know incentives matter. We know prices matter. Lots of examples in behaviour. You know, the switch from unleaded petrol, how fast it happened on the basis of a relatively small price signal, particularly if there's an alternative product. So it's right to think about prices as in relation to alcohol. But actually also think about incentives more generally. A lot of them are more subtle, particularly around discounting effects. I mean, a colleague of mine, David Halpern from Harvard, gives the example of procrastination being one of the dominant forces in behaviour, and indeed the lack of behaviour change in much of our life. You know, so exercise is one of the examples he gives. So basically, it always makes sense to exercise tomorrow, right? So if I think about it, all the benefits are discounted into the future, whereas the pain is up front, the sweat and effort involved. However, if you think about tomorrow, well, now I also discount the effort and the sweat involved, and actually it makes perfect sense. So literally, when we think about it rationally, we think, well, I will exercise tomorrow. It's quite sincere, and that's always true. I'll exercise tomorrow. So it takes you into, well, what kind of things would you do? And I'll touch on those a little bit more. Norms. Now, the end of Mindspace is norms, and that, of course, cuts very much into big society. So one of the most powerful influences often on our behaviour is just what other people do. Not what we think we should do, but just what we see other people doing. So the everyday example of it is littering. So essentially, the more litter on the ground, the more likely we are to drop litter on the ground. And it's a very robust effect. It's sort of 8 to 10-fold differences in the probability we will drop a flyer in our windshield according to the level of litter on the ground. And that's true also for many health behaviours. So one example in the paper is around, actually it's true both for sexual behaviour but also alcohol, that students, in fact a lot of us, but particularly students, overestimate greatly the amount of sex that other students are having and the amount that other students are drinking. And there's quite a lot of good evidence that if you inform students indeed actually works in the general population too, about what's the actual behaviour, their behaviour in turn changes. You can sort of see why. At 1 o'clock in the morning you'll hear the sort of drunk rugby club stumbling back home. Are very salient in your mind. You don't hear all those who are sitting in the library quietly. Salience effects, I kind of touched on it in terms of exercise, but even the design of physical spaces that you make the exercise option easy, or commitment devices. So one of the examples we put in the paper is around smoking. We think there's quite a number of promising approaches, and one of which uses commitment devices. So if we make a commitment to do something, verbally or in writing, whatever, it does have big impacts on our behaviour. I mean, everyday example from Chialdini is on restaurant booking. So you book a restaurant, and quite a lot of people then don't turn up for their appointment. So if I'd said to you, you've just booked your table, and we say to you, would you let us know? Will you phone, please, if you're not going to make it on Thursday? They had a restaurant with don't attends of about 30%. So they do the same thing, but they just make one change. We'll try it now. So I say, will you let us know if you can't make it on Thursday? Sure. Exactly. So sure. You just respond. So the staff were asked to pause at that moment. The rates of don't attends dropped from 30% to 10% in that moment. So we're quite interested, and we're doing some trials with Boots on commitment devices around smoking. So the idea that the individual might make pre-commitments. Indeed, you might imagine in benefits would be an interesting example whether someone will put aside a small amount of money on a regular basis, and then they'll get it back at a given future date if they haven't been smoking. The last thing on this section is on social networks, which is, if we do follow, I mean, a lot of these factors are well known about smoking, drinking, and so on, but actually social network effects are also very powerful influences on health in their own right. And a fascinating literature, although it's curious how it doesn't particularly affect much of our practice. But, I mean, Ada Cohen, for example, spent about 30-odd years studying the common cold to try and work out, well, what is it that, just often you get exposure to the virus doesn't mean you develop full-blown symptoms. The strongest factor he ever found in predicting whether someone did develop it was basically if you can answer yes or no to the question, if you've got a problem, is there someone you can talk to? Basically a network measure. And we know a lot about the pathway, we know a lot about the functioning on the immune system and so on. So that itself is very intriguing as to whether, if you genuinely could do aspects of a kind of qualitative side of big society and make us feel better about each other, as to whether that would have direct health effects in its own right. On the back of an envelope, those effects look very large. So fairly briskly, I just want to also then talk about the service side. And for PM yesterday, talked about modernisation, both being in terms of the demand side, public health, but also about the services themselves. In a patient hotel, it looks a lot like basically looks like a hotel. You go for your treatment. Instead of staying in the hospital, you stay in this environment that looks and feels like a hotel. It's actually, the staff look like they're hotel staff, although they're actually nurses. The key result, as it were, is that the clinical outcomes appear to be better, the costs are substantially lower, and patient satisfaction is much higher. So what is it about these patient hotels that seem to do it? Well, when you turn up at the patient hotel, unlike would often happen in a clinical setting, most hospitals, instead of, if you want to stay with your partner, you're being directed to a sort of manky armchair in the corner, or more likely relatively limited visiting hours. There are 2 beds in the room. You'd be expected to stay, actually. And so if you're there for a few days, you'll actually participate in many of the care elements. You might learn how to clean a wound or whatever. So you acquire these skills, and actually one of the other unexpected effects in the patient hotels is that patients and relatives help each other in the kind of common spaces. So imagine you've been there 4 days, someone's just arrived, they're nervous and uneasy. Well, you create a kind of mutual, network and support. So in other words, instead of turning your back on these potential capacities, you utilise them. I'll just give you one other, which we've talked about a few times, which is around reciprocity. And one of the things, again, often cited in healthcare is the concern about ageing demographics and what this means. Well, Japan is particularly interesting in this respect because its demographics are, in many ways, the most advanced in the world. So they've had a system for quite a while now, which is growing in scale, of essentially care credits, which is reciprocal care credits. So what it is I'm in Tokyo, I can't look after my mother, she's 500 miles away. What I'll do is I'll look after someone else, and another elderly person. I get these care credits in the system, which I can then give to my elderly mother. And they can use it, in inverted commas, to kind of acquire care from someone else. Well, this is experience qualitatively very different than paid-for care, but it increases the total level of activity, and it hinges very much on reciprocity and its power. I'll just give a personal example before I just kind of really drawing to a close to illustrate this point. I mean, I myself had some of you may know, my youngest son had a tracheostomy for 4 years, first 4 years of his life, and so he doesn't have it anymore. But you acquire great technical skill in managing a tracheostomy after a few years. You have to change the tube on a regular basis and tapes and so on. And occasionally, my son would get his fingers behind it and pull it out, and then you had about 2 minutes to sort the thing out, or it doesn't end well. Anyway, as I said, he's fine. Well, we dealt with lots of consultants and so on. At the end of that period, he said he didn't need it anymore after 4 years. We said to the many clinicians we dealt with, if there was someone else who needed care or some parents wanted a weekend off, we would happily do that, right? Because we were never asked. We were never taken up on that kind of offer. We haven't generally built public services which ask something back or facilitate that kind of reciprocity. So it's not just, as I said, an efficiency argument. Indeed, it also goes to the underlying etiology if you buy the arguments about social networks and their health impacts, but also changes the quality, the nature of the health service themselves. So just in conclusion, I guess let me at least try and convince you that there's a very strong relationship actually to many of the kind of underlying behavioural stories, and that big society story isn't some separate thing, but actually certainly viewed through social networks is very integral to the same. And the last remark just to make, maybe we'll come back to it in discussion. There's been some discussion, certainly amongst some critics, about, well, actually is nudge some kind of hard alternative? Well, clearly it's not. It's a complementary tool. There's a number of approaches that you can use. It doesn't mean you'll never regulate. Indeed, a lot of the story becomes just about smarter regulation and approaches. But maybe we'll come back to that.
Thanks very much.
Thank you.